slides, por favor. Would you like to try?
Yeah, now I can try. So share. Do you see my
Uh,
do you
yeah.
see a PowerPoint window now?
Uh-huh.
Let me see. I will just move to PowerPoint myself. So if I now I hit presentation mode, is that does it display correct, or is it the disposition modus? Do you see the big screen, or do you see
I see the
the
small one. I see the small
yeah,
one.
yeah, okay. So then I will do like that. So now you see it.
Oh, yeah, yeah,
Okay.
yeah. Yeah, great. Yeah.
So yeah. So if I do like that, you see it. Yeah.
Yeah, yeah, yeah.
Okay.
And then how many rapids have you performed up
Uh,
to now?
it's not more than about 10, 12 cases because when I sort of invented the technique, soon after that we started doing sharing of good splittable livers in Scandinavia.
Mm-hmm.
So a lot of the livers that I would like to split locally are not really available. So what we are doing now is that we are going to start a living donor program
Yeah,
because
great.
I do all the pediatrics transplant in Norway. So I already do about 50% of those I do living donor.
Mm-hmm.
So it's really the same operation. So now we will switch to living donation instead,
Yeah,
which I think it's perfect. It's the perfect setup.
yeah. And do you still perform pancreas transplants as well?
Yeah,
Yeah, I'm asking that because I remember when we met in Rio,
yeah,
I asked you some questions about it.
yeah. We don't. Well, funny enough, the referrals are decreasing actually, and I think it's probably due to the fact that all the new gadgets probably improve diabetes care. So we
Yeah,
see
yeah,
less need for the procedure,
yeah,
but it's still let's say we do 10 to 15 a year or something like
yeah.
that.
I agree. Yeah, back in time, well, the maximum that I have performed was like 40 in a year. And
Correct.
yeah, but in the last years, I would say that I have performed like 4 or 5 cases a year.
Yeah. It's exactly the same development in Oslo.
Yeah, I don't see so many reasons as in the past.
No, no.
And it's far
So
more
I
dangerous. Far more
yeah,
dangerous.
yeah. No, so I think that's maybe a treatment that will gradually disappear as the diabetes care get better. And in our hospital, we are also taking part in a trial with allogenic stem cells that have
Hmm.
been
Hmm.
induced to be islets.
Yeah,
So I mean, there are, and actually a subset of these are modified to be hidden from the immune system. So we actually do them intramuscularly. So it's, I mean, things are moving. So I think in the course of some years, I'm not sure we will do many pancreas
yeah,
transplants anymore.
yeah, like the insulin pump and stuff like that.
Yeah, yeah,
Uh,
yeah.
it's not worth adding a pancreas graft, probably.
Well, it's a complicated treatment, and the complications you can't avoid that you have some complications. So yeah.
Yeah, yeah. Antonio Calil has
Antonio
arrived.
Calli, I know Antonio too from Porto
Hello,
Alegre.
Paul Dag.
Hello,
How are you?
hello. Very good, very good. Nice to see you.
Long time you are not coming to Brazil.
No, I haven't had the opportunity for some years to come, but I would love to come again. I really
Good.
enjoy Brazil.
Let's try to organize something to
Yeah,
to
yeah, absolutely.
and you can visit the south of Brazil.
Yeah, yeah.
Very
That would be fantastic. That
Yeah.
would be really fantastic because I miss that part. I've been to several places in the north and in Rio and São Paulo, but never south of São Paulo.
good.
So
Let's organize. Okay, Nicoluzzi, let's organize
Yeah.
yeah,
next
Yeah,
time.
oh, yeah, yeah, great. The only difference is that depending on the time of the year that you come to the south, you imagine that you're at your own place in Norway. In Norway, it can get very
you
cold
know.
down here.
Well, I don't believe you. It's that cold. It's like a Norwegian spring anyway.
It can get
Yeah,
like -3 or 4 in some places in here, you know.
Yeah, 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 yeah.
yeah,
But
but not
that's
like Norway. Yeah,
Yeah, not
no,
like
no,
Norway, I would say, but
no,
well,
no, no.
no, Norwegian spring,
Yeah,
yeah.
yeah,
Norwegian spring, probably. Yeah.
yeah.
Khalil, have you ever been to Norway?
No, not yet, not yet.
Me neither.
My
It's it's a good time to go in the Norwegian summer to go to the far north.
Yeah.
Yeah,
To see the midnight sun.
Now
Or,
the day is about 18 hours already, Paul Dag.
well, it's still a bit early. It starts in May. It gets really bright, and then until mid-September.
oh, great.
Mhm.
And around end of June, yeah, it's very. If you go north, then the sun never sets.
Mhm.
So you have the
Good.
midnight sun.
Yeah. And Khalil, remember in Paris, it's summertime, it went up to 11 sometimes in the evening.
Uh-huh. Yeah.
I used to think about how could the birds stand that?
Yeah, 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 yeah.
Because here in
You
Brazil,
know,
they sleep like early.
yeah.
Yeah.
I can remember in Rio, it's like someone switches off the light. It goes very very quick.
Yeah, 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 yeah.
Yeah, it's like 20 minutes and then it's completely dark.
Yeah, very different. Well, we're supposed to start at 10 p.m. In Norway, 5 p.m. here. So we're in time. There's another panelist that's about to enter, but we will start slowly, and then uh, he arrives afterwards. So
Right.
I'm just gonna make a formal presentation beforehand.
Yeah, yeah,
So this course is the HPB 25. That's the fifth version of it. We've been organizing like the universitarian certificate of HPB surgery that I had attended back in time in Paris at Paul Bruce.
yeah,
So I thought about trying to organize something very similar here in Brazil. So we are doing in this fashion, inviting some international guests like you and national guests like Khalil, so that we are trying to bring to Brazil the quality that we had lived abroad. So I'd like to introduce first our panelist, Dr. Antonio Calil, who is a digestive surgeon and HPB surgeon. He works at Santa Casa Hospital Porto Alegre in the south of Brazil. Dr. Calil, another time, I'm very proud to have you here with us.
I'm very happy to be with you and especially with our friend Paul Dagline in this meeting.
Yeah, and Dr. Paul Dagline, I'm very happy that you accepted our invitation. So you have a very busy work, and still in the evening you have time for your lecture. So Dr. Paul Dagline is the head of surgical department at Oslo University. He was the person that presented the rapid concept to the world. He's from Oslo, Norway. In today's lecture is about the technical aspects and indications of rapid in colorectal metastasis to the liver. So, Dr. Paul Dag, thank you again for being with us tonight and have a good lecture.
Thank you very much for the very kind invitation, and I'm particularly happy to join in with Brazilian friends, since I have spent quite some time in Brazil and know a lot of the colleagues there. So I'm sharing my slide, and I guess you notify me if there is any problem.
Sure.
To talk about the repeat procedure, we have to start with a background. So basically, I have used 20 years of my life to explore the potential of transplanting patients with colorectal liver metastases. And anyone that is old enough in this game know that this was a strict contraindication back in the days. So I can remember the first time I gave lectures on the field that people literally banged their head and thought we were crazy. But as we got more data, what people would usually say was that, well, maybe you're onto something, but we don't have livers. And I thought about this a lot. I thought about it for many years. How could we provide livers more easily for patients with colorectal liver metastases? And that resulted in the repeat concept. So the background is, of course, that with the advent of transplant oncology extending from HCC, walking into colorectal liver metastases and neuroendocrine metastases, we need to have access to more grafts. And what we are really looking for is what we can call transplant benefit. So transplant benefit is basically the survival gain that can be offered by transplantation, in this case B, as compared to any standard of care treatment. And notably, it doesn't really matter what treatment the standard of care is, whether it's ablation, surgery, chemo, doesn't matter. If there is a big difference, there is a big benefit. The other thing to consider is that if you are willing to allocate liver grafts, we usually will require that the survival at 5 years is above a certain limit. And one might argue what this limit should be. Some would say 55, 50, 60, whatever. And it all depends on the transplant situation in each country. But above a certain limit, it should be. Now, this means that we have to have some way of selecting patients, because if you transplant patients for cancer, this is not an off-the-shelf treatment or a standard treatment for every case. It's a very selective treatment, and it's based on biological selection, where we make an educated guess on prognosis after transplant. And this is what I've used, like I said, 20 years to find out. So if you want to transplant patients for colorectal liver metastases, basically it's an elimination game. And what we are looking at, there are certain features that are non-modifiable and should be avoided. And these are related to the primary tumor. So right-sided tumors do much worse. They do worse whatever you do with them, whether you treat them with chemo or liver resection or liver transplantation. Also, undifferentiated tumors or signet ring cell differentiations are associated with bad outcomes. If you have extrahepatic disease, that's an absolute no-go. So each transplant has to be preceded by a staging. So when you open the patient, you have to stage the lymph nodes. If they're positive, there is no big idea to do a transplant because it will be palliative, whatever you do. Whereas we know that the size of the biggest lesion is a prognostic factor. That's something that is modifiable. We can treat the patient with good chemotherapy and get the sizing down. And the same is for what we call the metabolic tumor volume that I will go into in slightly more detail. And then we have mutations. BRAF mutation is very bad. The same is TP53 and KRAS co-mutation. And those are non-modifiable, so that should be avoided. But CA is a modifiable factor. So the lower, the better, and it should be lower than 80. And then the response to chemo, progressive disease is a no-go. So good response, at least 10% resist. And then you should have observation time. We used to claim that you should use 24 months. We have later abandoned that, and what we usually now use is 12 months of observation. And the way to select has been published in the Lancet in 21 in the IHPBA guidelines, and you can follow this algorithm as a way of managing patients and to select them. And what we know now is that if you have an Oslo score, which is basically a scoring system that considers chemo response, tumor diameter, CEA level, and timing with a scale of 0 to 4. If you have an Oslo score of less than 2 or 2 or less, and the volume of enhancing tumor mass in the liver is less than 70 cc's, your outcomes will be extremely good. And this was published in JAMA Surgery back in 2021 as well. What has happened later is, of course, as you all are aware of, that we now have the Transplant trial. So the Transplant trial doesn't show you anything new that we didn't know. But the importance of this is that this is actually a randomized trial. So if you look at the randomization here, they were randomized to transplant plus chemo or chemo alone. So in the intention to treat analysis, it's 57 versus 13 at 5 years. But in the per protocol analysis of the mouse is moving. In the per protocol analysis, it is 73 against 9%. And that's a staggering difference that can't be overlooked. And this has practice changing implications for how we approach liver transplantation and colorectal metastasis. So in the future, I mean, no doubt that this will become an added tool in our toolbox on how to manage. But I urge everyone to think very careful about patient selection. So the state of the matter is that of all cancer indications, if you look at benefit of the treatment and level of evidence, the only indication that has solid evidence and in terms of the benefit obtained is actually colorectal metastasis. There are no randomized trials for the other indications. So this is, of course, things that will change the way we think. And I will be a little provocative because the way old guys like us, or at least me, the way we have thought about colorectal metastasis is essentially that a minority can be offered a liver resection, and we will do anything to try to resect them because it's always better than palliative chemo. The problem is, however, then when we have three alternatives, liver resection, liver transplantation, and chemo, we have to start thinking more critical about what we offer to the patients. Because it defies pure logic that the good outcomes you see in non-resectable disease, it's simply not logical that exactly the same will be the case even if the patient is marginally resectable. So I think that's where this field will go. Some of the transplant will be done for the gray zone patients where resection is likely to yield an outcome of 20% survival or even less. And if these patients satisfy transplant criteria, clearly, I think in the future we will, to a greater degree, transplant them rather than doing two-stage hepatectomy or ALPS or whatever. But if they are not satisfying the transplant criteria, of course, then still we would do two-stage or ALPS or whatever. So this is the background. And this paper came out in the annals last year because people are looking at this development and thinking that this development in transplant oncology might seriously harm the waitlist dynamics in many countries if we are really going to go into this. So we have to find ways of expanding the donor pool. And of course, we know that in a deceased donor program, we know that at least 15% of the livers are technically splittable. And that should be really systematically done to expand the pool. We also have in most countries, we have living donor liver transplantation, but in the West, it tends to be far, far less than in the East. And like in our country, we do it only for the pediatric cases. And the small grafts are, there are problems associated with small grafts. And this is, of course, the question we are facing today. Because the thing I was asking myself in 2012, I was running animal models, and specifically I was working with small for size syndrome in animal models, and I thought, is it possible in any way, shape, or form to use very small particle grafts in patients with malignant tumors? And the idea was that if you could do with a small graft like we use it for a pediatric recipient, then we would never harm the waiting list in a deceased donor situation. Besides, it would be a very nice model for living donor transplantation. But if you're going to do this, there are two immediate problems that you have to solve. If you put in a very small graft, we know from the living donor experience very well that this does not provide sufficient liver mass. So you will end up with a postoperative liver failure. The second problem you will face is a fairly high likelihood or a possibility for small for size syndrome. And what do we mean by small for size syndrome in this setting? It's actually portal hyperperfusion with increased pressure. And this leads to hepatic microvascular damage with destruction of the sinusoids and arterial ischemia due to intense vasoconstriction due to the buffer response. And the clinical syndrome that develops is characterized by hyperbilirubinemia, ascites, and synthetic failure, and failing regeneration, and in the end, an organ failure. And these patients, if not successfully intervened with, will usually die in the course of 2 to 3 weeks. So a solution to those two problems is essentially what is required if you're going to use very small grafts. So the rapid concept was published actually at the same time I was in Brazil. And part of the drawings I made in my apartment in Rio de Janeiro. But I did the first surgeries in 2014. But then I thought this is so provocative that I will wait a year and check that everything is okay before I publish it. So that's why it came out in 2015. Basically, the way to do it is the way to solve the problems is that you have your patient with tumors. And the first technical thing you have to consider is that you have to be able to split the liver in a non-tumorous area. So here it's schematically drawn that this patient would be very nice to do just a 2-3 resection. You can have different configurations. And nowadays, I usually tend to do a left resection instead, or to make sure that I have the middle hepatic vein accessible. I'll explain why. So the first thing is to do the resection, and the whole idea about the resection is to provide space for a graft and make sure that we can have an adequate venous outflow. Because bad outflow is very dangerous in this setting. And to have a good outflow, like I said, originally in the concept, we just used the left hepatic vein. But this might, due to the regeneration, you might have some kinking. So in some patients, we have been forced to stent the outflow. That has been successful, but it can be avoided. So it's even better to combine the two orifices of the left and middle hepatic vein and then do a triangulation like you would do in a pediatric liver transplantation is essentially the best. But when you have done this, you will usually keep a remnant that is sufficient in case the graft should fail. So that's the primary problem is then solved. You are not relying on the graft to provide 100% liver function. So you have time for the graft to develop. The next problem, let me see there. The next problem is, of course, after you transplant your graft. In this case, it's drawn the way I did the first cases with an end-to-side to the portal trunk and then end-to-side to the common hepatic. It doesn't really matter. You do what fits best. The point is that we want to have fast liver regeneration. And the way to do that is to divert the portal flow to the graft, predominantly to the graft. But we don't want to do like in an ALP setting where you just ligate and you don't know what you're doing. What we tend to focus on is that we will like to have control over the hemodynamics to make sure that we have optimal hemodynamic conditions. So I'll explain that in more detail. Then the patient is closed. We take a CT on day 1. And then every 7 days, we take a CT to measure volume growth. And then the idea is to do the final hepatectomy when the graft to body weight ratio approaches 0.8. That was in the early days. We are not that. We think you can go lower than that as well in most cases, depending on the pressures, or 35 to 40% of standard live volume for the patient, where we use the Vaughey formula. So, of course, the rapid doesn't come without any inspiration. So there are a lot of, I would say, I would not call it a totally new new innovation. It's actually an evolution of a lot of technique, like auxiliary transportation that I learned when I worked in London in the early 2000s with Mohammed Rela and Nigel Heaton. But the unique thing about Rapid is that we are, unlike other auxiliary transplants, our idea is to keep the auxiliary graft rather than the native liver. And that we are so focused on making sure that we have the correct hemodynamic setting. So regarding hemodynamic and metabolic demands, these are intertwined in a very delicate way. We know that we have the buffer response that we have to consider. So if the portal flow increases much, we might have detrimental arterial vasoconstriction that disposes to hepatic artery thrombosis. We have to have a perfect outflow. Metabolic demand of the patient is usually not that critical, so I'm not too concerned about the graft size, really, because the graft will usually regenerate very nice. But what I'm concerned about is the graft quality. And what do I mean about quality? I would like to have graft that is very compliant, because a compliant graft will accommodate high flow without very big increases in pressure. So that's a very good quality graft when you consider that your outflow is perfect. So the way we do it intraoperatively is that you have done your transplant, you measure, you put in a pressure catheter in the portal vein, you put flow probes on the graft artery and the graft portal vein. Then we measure the pressure under steady state conditions after reperfusion, and the patient is completely stable. Of course, you also measure the CVP, so you know your gradient. And then we clamp the portal vein to the remnant liver, to the right remnant liver, and we read out how much does the pressure increase. And we usually do that a couple of times to make sure that we have a consistent reading. If the portal vein pressure in the main portal vein with a closed right is below 16, we do nothing. We accept it. But I would not like to have the pressures higher than 16, because we know that the risk of negative impact on the graft increases by increasing pressures. There are very nice papers on this in liver resection, for example, with small liver remnants. And to my mind, a lot of the problems seen in ALPS has to do with not considering this. Also regarding flow, if you have a portal vein flow per 100 grams of liver weight over 300, you have a portal hyperfusion that is too high. So then we tend to think of modulating slightly independent of the pressure. And finally, we look at arterial flow before clamping, after clamping, and then after releasing the clamp. Because if you have a very heavy vasoconstriction, you should be careful. In case you have to modulate, you have several ways of doing this. You can do splenic artery ligation. But these patients, if you do this in a colorectal cancer patient, these patients don't have enlarged spleens. So the effect of splenic artery ligation is very modest. You can use somatostatin, maybe in addition to splenic artery ligation. finally, if the pressure is too high, you can, instead of closing the portal vein, you can band it to narrow it. And then you can calibrate it. Finally, the protocol states that if it's very high pressures, like it is if you do this in HCC with a cirrhotic liver, then you have to do a portal cable shunt to manage the small for size problem. So the take-home message, I would advise anyone starting doing the procedure, you should start doing this so you get an idea of how the hemodynamics works. The truth of the matter is that in colorectal patients, so far our experience is that you don't have to modulate. The pressure, if you have a good graft, perfect outflow, the pressure is usually acceptable and the flow is usually acceptable. So it usually runs very nicely. So unlike ALPS, I'm not too focused on that we have to do the second stage in 10 days. Instead, I would say if you think there is a big rush to do it, I think you do it in the wrong patient. If you're concerned that the cancer will spread in the course of 2 weeks, then you have picked the wrong patient. You should not do this in patients where you're that concerned. So here you see a typical scan, day 1, day 7, day 15, and already you have close to a doubling of the graft volume. So in this case, second day was done on day 17. You see the native remnant. You see the graft cut surface here. This is the remnant out with tumors, and here the graft, which is now big enough and ran very well. So just to present the first case in the world, this guy had a rectal carcinoma. He was diagnosed in January 2013. It was a T4 tumor, 40 millimeters. He was considered to have lung metastases, and when I applied to the ethical committee to do this procedure, they thought I was totally crazy, so they said, no, you can't do it. And then I asked to come and present it orally, and then finally they gave me the permission, but they said, we think you have to accept, go beyond limits, and you have to accept also patients with small lung mets. So we accepted this case. Because he had a couple of nodules in his lung. He had lesions in every segment of the liver. You can see quite small lesions throughout, and they were in every segment. I resected segment 1 to 3 in that particular case, and then we did a transplant with a 330-gram graft. This guy weighed 90 kilos, so the graft to body weight ratio was 0.36. I think that's the lowest one in the world, at least at that time. And when we measured pressure repeated times, the pressure was just 14 millimeters of mercury. So that was totally acceptable, and we stapled the portal vein off. So here you see his native liver. All the tumors were fairly small, so you can't really tell on the outside. And the clamp here is on the left hepatic vein. And here you can see the hilum where you have the portal vein anastomosis, and the artery comes here and goes down to the common hepatic, which is here. And all these patients I do a Roux-en-Y. Some colleagues have done direct duct to the left duct. I don't like that because I like to, for the second stage, I like everything to the left of the Roux loop to be well defined, so I can just run a stapler here across here when I'm going to take out the liver. Because you can just staple off the whole ligament, and then you staple off the right hepatic vein, and you're finished. So that's, in my view, the best way to do it. And here is the typical picture. So when you do your CTs and you have a mixed phase, you will see the effect of deportalization, where you have a very slow filling here of the remnant liver, and nice filling of the small graft. And typically the patients will have an initial growth, and then they will might have a phase where it's more steady state, and then it takes off again. And it grows really nicely when you look at it. In this case, we have 50 days. So this was started out as 330, ended up at this time, I think it was around 1100. So it's really staggering growth. But what can happen is that if you are relying on just the left hepatic vein, you might get kinking. So an important tip is to rather make the resections in that way, so you have the left hepatic vein orifice. Then it's easier to get a very good outflow over time. And typically, at the second stage, you might get a little bounce in bilirubin, but it's almost within normal values, and the INR might bounce a little bit, but it's not a liver failure as such. It's they usually recover very nicely, and the transaminases are usually very low. But one peculiar thing that you can think about, that you don't think about before you do it, is how can I monitor this? Because what we usually do if we do a transplant is that we look at blood tests daily, follow the transaminases, and then bilirubin, INR, and so forth. And we do some ultrasounds. The problem with ultrasounds is that it's a momentarily, or it's a brief moment of examination, but you don't know some hours later how the graft is doing. So, and the other problem is that if you have two independent livers and you look at blood samples, you don't actually know which liver is producing what. So a very nice way of dealing with this is something called microdialysis. So we started doing research on this way back, and we actually used it for pediatric liver transplantation. As you probably are familiar with, is that the incidence of vascular complications in pediatric liver transplantation is larger than in adult liver transplantation, and it's particularly high in the very small ones. So what we started doing after this research project is to use microdialysis catheters. Now, these are tiny catheters that you can put into the liver and just externalize the catheter. And it's actually a tiny dialysis membrane at the end of the catheter. And then you have a micro pump, and you pump fluid into the catheter, and there will be a dialysis process at the catheter tip, and you can retrieve whatever you like. But the commercial kits and the commercial analyzers do measure glucose, pyruvate, lactate, and glycerin. And it turns out that the lactate to pyruvate ratio is a very sensitive ischemia warning sign. So you can do this how often you like. So we typically do it twice an hour in the beginning, and then we do it hourly, depending on how the need. This is a very nice add-on if one has the possibility to do it. Now, what is the outcome of the RAPID trial? If you read the paper, the primary endpoint of this trial was to look at the safety of doing the procedure and to explore if it's possible to do total hepatectomy within 4 weeks. How many can be undergo a successful hepatectomy within 2 weeks? And actually, in Europe, we were able to have a consortium of 6 centers, so 3 in Germany, no, 4 in Germany. So Jena, Tübingen, Munich, and 3. Jena, Tübingen, Munich, and then Brussels, and Padova in Italy, and us. So we looked at graft regeneration, and as you can see, we have a mean volume increase in 14 days of over 100%. And the median interval time across these transplants were 14 days. So it's very reasonable time. And like I said, I don't think the interval time is very critical. There is no point in rushing it. On the other hand, if you wait too long, the second stage hepatectomy might be more cumbersome or complicated to do. If you look at safety, there was only 1 death. That was actually one of our patients, and I think we selected a very poor candidate. There was a guy that was old in this context. He was 67, 68 years. He had complicated primary surgery for his sigmoid cancer with perforation, a lot of reoperations. So he was a slightly bad case. And the cause of death in that case was hepatic artery thrombosis on day 44. So well after the hepatectomy, and he developed biliary sepsis despite we managed to open the artery, but he developed biliary sepsis, and he was not a good candidate for any rescue transplant, so he died. But so if we look at it, we had in the whole material 1 death, which equates a 90-day mortality of 4.3. Majority of these patients were living donors, so there was no donor mortality, no major complications at all, like you will expect in segment 2 or 3 donation. Our colleagues in Jena have also looked at their own material on portal vein embolization, ALPS, and RAPID. And as you can see, the absolute volume growth is much better in RAPID than it is in ALPS. And portal vein embolization, we already know that ALPS gives better hypertrophy than portal vein embolization in most cases. But RAPID is even better than ALPS. And I think the main reason is that this is like when you do an ALPS, you are dealing with a chemo-ridden liver. It's not prime quality, and you might have to clean it also. So what you're actually doing is you are taking an old trashy car and trying to make it up. But in RAPID, we are dealing with a Porsche, with a V6 or Boxer engine. So it's a much better deal. So the regeneration is much better. So this has also inspired some colleagues to pursue this in well-compensated cirrhosis and HCC, where there is no good other living donor. So this is the pioneer here has been my friend Dennis Balci. who works in Istanbul. He has done around 10 cases, I think now, or even more. And the peculiar thing here is that if you do it in cirrhosis, you have to do a portal cable shunt. And you have to pay attention very closely to the flow and pressures. But as long as you do your shunt, your flows and pressures are okay, this works very nicely. And then at the second stage, you go in, you close the shunt, you do your hepatectomy. So these cases have been also published. And quite recently, I think it was in about 6 months ago, they have started a prospective trial, rapid HSC at Borbus. So they have, and they do it with, I think, mostly deceased donor, but some living donor as well, maybe. So they are doing a prospective trial, the trial to validate this in compensated cirrhosis. In Norway, we don't do it simply because we don't need it. For colorectals, we need it. So our current setting is that we go for living donor. The other thing that has happened is that the International Society for Liver Surgeons has endorsed the principle, and at the annual meeting in Zurich in 2023, there was separate consensus conference on rapid surgery, where although the literature is very sparse on this field, there is a lot of literature from the living donor transplantation literature, and from uphold transplantation, auxiliaries, and so forth. So this was a very nice conference meeting, and the consensus recommendations came out quite recently in the International Journal of Surgery, and can be read there. I think it's open access. So there are a set of recommendations, because I think everyone that wants to go into this field should collaborate through the rapid surgery initiative to make sure that we generate as much data as possible to make this as safe as possible. So going back to the first case in the world, the paper, the guy was operated in 2014. This is the same guy, I think it was last year. He actually, when I met him the first time, he was planning his funeral because he was on third line with slight progression. I operated in the summer of 2014. In 2015, I got a greeting card because he had got married again. He's now, in a few months, he is 11 years out. He's totally cured from the disease with 330 grams of liver. This is in 2014. I showed this picture earlier. His liver here, about 1,000 grams. Here are his lung nodules. They are clearly resectable. You see it in the top of the right lung, and then in the basal part of the lung, quite small nodules. This was in 2023. Here's the nodule, here's the nodule, nothing happens. This is not cancer. This is simply not cancer. And here you see his nice beefy liver, and he's totally cured. This is his CEA levels. Directly after the procedure, have stayed normal ever since. So it's possible to cure patients. What is the future here? Well, there are a lot of implications. What I think we will see, if we just think of transplant oncology, is that we will get a range of recipients with normal liver function, where we do this for pure oncology. This means that they have quite good function to the extent they haven't been killed, their liver function hasn't been killed by too much chemo. They have no portal hypertension, usually. So they tolerate small grafts simply. So I think we can also see a general trend in shifting to the left, accepting smaller grafts, doing more left lobe donations, which is an interesting alternative that can be combined with a rapid approach as well. But the interesting thing here is that you can lower the donor risk, because the donor risk is proportional to the amount of liver you remove from the donor. And for programs that do not do adult to adult like us, we do it just for kids. Rapid is extremely tempting to do living donor, because it's the same operation in the donor, so it's well established. And of course, time runs fast, and we see now the revolution of minimal invasive surgery. I was one of the early adopters of living donor laparoscopic nephrectomy. The problem with laparoscopy is like being in Brazil, going to one of the big steakhouses and then having the delicious Brazilian meat, and they give you chopsticks to eat with. And that's in many ways, or if I put it on the edge, that's the way laparoscopy will work. It doesn't really permit you to do a lot of the more advanced things like suturing fine structure or doing a transplant. Some few experts in the world can manage it, but for the average center, it's not an alternative. But then we have robotics, and this is during a left lobe donation in Riyadh, when I visited my colleagues there, because we have some cooperation with them. So clearly, these donors that donate segment 2 and 3 graft, they go home the next day, which is very tempting. And as you all know, the transplants can also probably in the future be done robotically. So I think there is a huge revolution waiting for us to be developed that really can transform transplant oncology to be a bigger part of the HPB programs where you have transplant available. So if I were to conclude, I think the rapid technique is a possible strategy to increase graft availability. And the big advantage is that you can get the best of both worlds. You can get access to liver grafts with no negative impact on the regular wait list, combined with a very low living donor morbidity and mortality. The surgery is slightly complex, and it's well advised to be very careful in the patient selection, focusing on low surgical risk recipients, meaning not major surgery in the upper abdomen beforehand. They should have a preserved liver function, not be have had so much chemo that the liver is bad function, and not having too much comorbidity. And as I said in detail, you should carefully consider the hepatic hemodynamics during the procedure and try to make the perfect balance to have a moderate portal hyperperfusion to ensure regeneration, but avoid detrimental hyperperfusion that will push the graft to small foci syndrome. And I think the future with the nice developments in minimal invasive surgical approaches may be very attractive refinements that will push this even further. So thank you very much for your attention, and I'm happy to answer any questions you might have.
Thank you very much indeed, Dr. Poldag. Great presentation, great series. And well, it's wonderful, absolutely wonderful, especially when you see someone like the patient that you showed that have more than 14 years. Is that so? 11 years?
Yeah, no, 11 years.
Yeah,
He's cured.
someone with rectal cancer, plenty of mets to the liver and mets to the lung as well.
Yeah,
And
well,
he,
they were not. It turns out they were not metastases.
oh, okay.
They are not metastases. I
Yeah,
mean, they haven't moved a bit in 11 years.
yeah,
So
great.
that's that's what it is. Hematomas, I don't know what it is. We don't care about them.
Yeah, yeah,
So because I mean, he has no symptoms. He has normalcy. Doesn't move. Yeah. So
yeah, that's absolutely great. Yes, certainly, as you showed in the very beginning about the oncological behavior is something
yeah,
that you must consider because someone like this with rectal cancer and plenty of liver
yeah,
mets
yeah,
certainly had a very favorable biology. Otherwise, it
yeah.
wouldn't be like so.
No, and that's the key issue. You have to try to pick patients with the good biology. So I have, of course, I've had due to all the developments in this field, I have been in contact, or I have been contacted by colleagues from all over the world. And for example, in the US, they tend to overtreat these patients. So in the beginning, they were transplanting disastrous cases like eye melt due to too much chemo, and that's the wrong way to do to see this. Then you are doing exactly the same failure, the error that the transplant community did early in HCC, where you think that you should rescue those that could never be resected, have big tumors and so forth. That's not the best way to do it. You should actually look for patients that responds very well to chemo and that have many lesions, but not too big lesions. That's the perfect candidate.
Yeah, I see. I see. Yeah. Yeah. Well, your results show it. So,
Yep.
well, I'm just going to introduce Dr. Marcus. He was operating up to now, but he had time to follow your presentation in his cell phone, and now he's
Right.
ready to discuss with us. Welcome. Dr. Marcus, would
Hello.
you like to start with questions?
Yeah, I could start. Yeah. Congratulations, Dr. Paul. It was a brilliant presentation and very, very interesting. I saw it from the beginning. I have some questions. Um, when do you prefer the liver grafts, prefer liver grafting or using it, in preferring it than ALPS and or two-stage hepatectomies, and or when you have indications for ALPS and two-stage hepatectomies, you prefer those strategies, or you prefer the liver graft donation.
Yeah.
Yeah.
So if you look at it, if you look at the outcome of ALPS or two-stage hepatectomy in a patient with, let's say, over 10 lesions, if we are quite honest about it, the outcome is going to be at best about 30% at 5 years survival.
Yeah. Yeah.
The recurrence rate is over 80%.
Mhm.
So I think you have to, if you have 10 candidates that are candidates for two-stage hepatectomy or ALPS, I will look at the ones that have perfect biology and satisfies transplant criteria. I will switch them to transplant because then I can maybe rescue them and cure them.
Yeah.
But if I cannot do it, if they do not satisfy my stringent transplant criteria, of course, then ALPS is better than chemo. But ALPS is not as good as transplant if the tumor biology is favorable. So it's kind of my thinking, but I'm, of course, I've done close to over 100 colorectal transplants, so I have a big experience in selecting. But I think some years from now, we will turn this on the head and say, look at the biology first. If the biology is good, transplant is going to outperform resection any day, any day. And I'll tell you why that is the case. If you have high volume disease, meaning you can measure this by a tumor burden score. So tumor burden score is has been published. It's essentially you plot the number of lesions on the y-axis, the diameter on the x-axis, and and then you get a point on the Cartesian plane. So the score is the distance from the origo, and that can be calculated by Pythagoras. So to find the tumor burden score, you make the square of the biggest diameter and the square of the number. So let's say you have a patient with 9 lesions of 1 centimeter. That will be 1 plus the square of 9 and the root of that again, and that's going to be 9. So a tumor burden score above 9 is usually high volume disease. There are papers out there now showing if you do have patients with low tumor burden score, there is a very good separation between R0 resection and R1. If the tumor burden score is above 9, there is no difference. If you do R1 or you do R0, the outcome is the same. And why is that? It's of course because we systematically underestimate the extent of disease, because there are a lot of micro dissemination we cannot see on our CTs or MRs. So even though you think it's just 9 lesions or something, it's usually not the case, and that's why they recur. And this has also been shown in a very nice paper from Rochester in New York, where they have a living donor program transplant. They took out all the livers and look at that systematically. And in 60% of those livers, there were undiagnosed lesions. And furthermore, in about 58% of all vanishing lesions had tumor cells that were viable. So the problem with liver resection is that a partial resection always have the risk of leaving remnant tumor behind. So if the biology is good, meaning that the transplant criteria like the Oslo score and metabolic tumor volume, everything looks good, transplant is better, much better. If the biology is bad, there is no difference. Maybe transplant is even worse than doing ALPS. But so that's the way to look at it, to my mind, and I'm quite confident that is what the literature is going to show in the future.
Just one question before Dr. Khalil asks you, because it's just a continuation of what he said. So, how do you see? You show that the transplantation for the patient who has, favorable biology is probably the best tool.
Yeah.
But compared to ALPS or two-step hepatectomy, what would you say about surgical risk and morbidity postoperatively?
Well, the experience from the RAPID trial is that the morbidity or the mortality risk is on par with ALPS. So we have, in the beginning, ALPS was a disaster. You had over 10% mortality. And then the registry study now published a couple of years ago showed a mortality just below 5%.
Mm-hmm.
So it's I think it's quite comparable.
Yeah.
I think one important aspect is that we will probably see a shift towards more minimal invasive approaches, that you can do much more of the procedure minimal invasively. So my anticipation is that these figures will come down.
Yeah. Yeah, for
And you
sure.
have to realize that the figures I'm telling about rapid, the number of rapids performed in the world is not big.
Yeah.
So this is even during an implementation period. So I think it will go down.
Okay. Dr. Khalil has the experience in Brazil of transplanting for colorectal metastasis. So your turn, Dr. Khalil, please.
Thank you, Dr. Paul Dag, for this wonderful lecture. We learned a lot with your presentation, and our experiences in the beginning. We have just one case, and with uh, left lobe living donation with a left
Right.
lobe from two from a sister to another sister with the same age, the same weight. So it's a very good case, and it's about almost 1 year and no recurrence just now.
Fantastic. Fantastic.
But until now, Paul Dag, in Brazil, the only way to transplant these patients is with living donors,
Yeah.
and it's not so easy to find this case. So
No.
for this, the rapid concept is really very, very useful for us. We have experience with pediatric liver transplantation. Of course, it will be good to use the concept of rapid in these patients.
Yes.
So you emphasized the indication as the. Are you listening me?
Yes, I hear you.
Okay. So as the use of the Oslo criteria, the four criteria of Oslo. Do you use are you more restrictive in this criteria for the living donors for rapid, or it's the same?
No, what we do now is that if you if you have an Oslo score 2 or less and your metabolic tumor volume is below 70 cc's and you're left-sided primary and all these things, you will get a normal liver graft because the survival is fantastic. So there is no argument against that. So we are actually in a position that we can give liver grafts for them. So what we are now approaching with rapid is that we want to explore new boundaries, because there are a number of boundaries that no one has looked at. So one of the boundaries is that I would like to, if you look at the recurrence pattern after transplant, because it's always a problem if you transplant for colorectal metastasis that you have a recurrence of 50-60%. But the key issue is that most of these are lung mets, and most of them are actually resectable. So what we did back in 2014-15 is that we looked at all our patients and then we backtracked all the CT scans. And what came out of that is that at least half of them, the radiologists were able to see, well, there was a microscopic nodule exactly there the time of transplant or before transplant. So I think that we have been transplanting patients with micro lung mets actually for a long time. So one of the things we are now have written a protocol for a study where we will, with open eyes, we will accept resectable up to 3 lung mets that are small and have been stable. Then we will do the rapid and do everything, and then we will go in and resect the lungs once the liver is okay. Because then we can give an opportunity to people that we normally wouldn't include. So we will use mainly the rapid approach to make sure that we can expand our offer and possibly develop the indications even better than we have done until now.
And you talk a lot about the hemodynamic assessment during the procedure. What about the problems that you had been in the because normally people talks that in liver mets there are low problems than
that's the experience actually.
Expected.
Yeah. So, but the reason that we did it this way is that I did a lot of animal experimentations with small size, and found what Otto had described, that the hemodynamics are very important if you have very small grafts. So we did this from the beginning. And it turns out in colorectal metastasis that you usually can get away with it. But if we hadn't done this, the cases done in cirrhotics would never worked. And in fact, Dennis Balchi, who did the first one, he did some where he didn't pay attention to it, and then he called me. And then during the next procedure, actually I had my phone on for like 5 hours, and we were discussing all the time, and he was transmitting the pressure measurement. So we ended up doing the shunting systematically, and ever since that, it has been successful. So hemodynamics is generically very important. So I'm a big believer in that you should just do it as a routine, but it's quickly done. You just puncture the portal vein, measure the pressure with the same line as you use for CVP, get from the anesthesiologist. And we use flow measurements in every transplant, so it's nothing extra. Goes quick. And it's very nice and one of the important thing is that in some cases you will see that when you get a portal hyperperfusion, your artery will constrict heavily. Then you should be careful, because if you have an artery thrombosis, your graft will usually not fare well.
Good, very good. Thank you.
André, any other question?
I have another question. When you do the first stage of the rapid, you not always ligate the right portal vein, right? Sometimes you do a stricture just
No,
not.
I have actually. I wrote up this procedure in the paper, so it's a stage. So you can do splenic artery ligation, you can do banding, you can do shunting. But it turns out that in all our colorectal cases, you don't have to. But this is but the protocol has been thinking of every possible situation.
Yes.
But it turns out if you have a very good quality graft and you have a patient like a colorectal patient without portal hypertension, usually it's fine. But my advice is to measure, because you get a lot of experience in how to judge the conditions. So I think that's a very good advice. And mind you, a lot of the problems in the Alps, I think a lot of the early problems, there were two main problems, bad selection, of course, but also that you have chemo damaged liver, and you just ligate and you push the flow into the liver, and it's too much.
Yeah.
It's too much.
Paul, the indication for cirrhosis.
Yeah.
You talk about portocaval shunt during the
Yeah.
procedure, in all procedures. What kind
Yeah.
of portocaval shunt?
So I personally don't do it because I don't need to. But the way Dennis Balchi has done it, and also I think in Paris, that they will use the left portal vein for the graft, and then they will take the right portal vein down and anastomose in an end to side fashion to the cava. And if that's not technically desirable, you can use a small PTFE, or you can use a cadaveric vein or something end to side. And it's easier to close than when you go in for the second stage. If you need to do something, if there is too much steel, because you have to make sure that it is not too much steel, you can actually also modify it with IR before the second stage, if needed. Because the interventional radiologist can easily get there via the cava once you have done the shunt.
And the use of the catheter for microdialysis, how
Yes.
you
Well, this is a Swedish company. It's called Microdialysis AB, also microdialysis, English written in English, and then AB is just an acronym after, and they sell these machines. So we have had it as a research instrument, and we still have it. So I tend to use it if I'm a bit concerned, about the graft, and I use it in high risk pediatrics. So I have done last year. I did 5 more living donor monosegmental pediatrics in 4-kilo kids. And when you have a monosegment, it's very nice to have this kind of monitoring, because you can look at the graft as often as you like, 3 times an hour or whatever. And the catheter is very. You just use a split needle, you puncture the liver and put it in, and then you take a resorbable suture and fix it very lightly to the connective tissue, and then you externalize it, and when you're finished, just pull it out. Nothing happens.
And the results with the left lateral lobe, do you think
Yeah.
that we will have a gain with the total left lobe for the future, as you proposed in one of your slides?
Well, yeah. Well, I mean, you will get to your goal quicker if you use a left lobe. On the other hand, I think a lot of patients in this setting can tolerate lower graft to body weight ratio than we believed many years ago. And this is, I know that the colleagues in Delhi, Aminder Soin and Prashant Bangui, they do quite a lot of transplants with fairly low graft to body weight ratio. So if you ask them, I think they will say that the limit is can be lowered. So, but I think if you are concerned about a slightly low, let's say you have a 0.5 ratio or 0.55 or 0.6, and you're not too happy about it, then you can do a left lobe and a rapid, and then you don't have problems. But you have to do
about
a two-stage.
yeah
You have to do a
about
two-stage.
okay, about the vascular complications, there is no
Well,
difference probably.
no, I don't think it's a very big issue. No.
So
But when you get the complete left artery, you might have a more limited artery when you do a segment 2 and 3. So it's and there will be variations here. So it can be you have to judge a little bit case by case, I think.
Thank
well,
you.
Dr. Paul, Dr. Khalil, and Dr. Marcus, I would like to thank you very much. But in Norway, it's 15 past 11.
Yeah.
So we have to, yeah, so we have to let you rest.
Yeah.
You are very kind to, to accept participating like this in such it's late in Norway. So,
Yeah.
and you have a busy agenda. So thank you very much for showing your
Yeah.
experience, Dr. Paul. And I also would like to thank Dr. Khalil and Dr. Marcus, who is someone that we operate together. And congratulations. I wasn't aware that they were using Rapid for HCC as well. So great.
Well,
Another great
that's
information as well. Yeah, in cirrhotic
yeah.
patients, this kind of field.
Yeah, and I think that's it's pushing the limits.
Yeah, yeah,
Yeah. So, like I said, I'm not happy to do that here, but because we don't actually have the need. But clearly, the world is moving, and that's the
yeah,
wonderful thing about cooperation and science.
yeah,
Things are
yeah,
developing.
yeah, yeah. That's one of the aims
And
of this Congress as well.
Yeah,
Show people all over because as is broadcasted
yeah,
from the internet. We
yeah,
have 1,100 people enrolled for this Congress. So we trying to share this
yeah.
kind of
Very
knowledge
good.
you have just shown.
Very good.
Okay, so thank you very much once again. I hope to see you in real next time
Yeah.
as the last. And
Yes.
thank you very much indeed, and have a good rest.
Yeah. Thank you for the invitation. I'm on call tomorrow, so it will be good. Okay.
Okay, see you.
Bye bye.
Have a good
Bye bye.
evening. Bye bye.
bye,
Yeah.
ciao.
Bye. So.